Pragnesh Vacharajani, the dynamic Pragnesh duo, as we call them. Background. On behalf of both of them, and on behalf of all the committee members of the FFPAI, I welcome you all to this series of endocrine. We have been having a series on endocrine updates by Dr. Om Lakhani, none other than Dr. Om Lakhani. This is our fourth session. And after we have done with the thyroid and diabetes and steroids, we are today going to have a session on the pituitary gland. It's a tiny gland situated in the base of the brain, but it is the master of all. So to speak to us on the pituitary gland, we have Dr. Om Lakhani with us. And to introduce Dr. Om Lakhani, I request Dr. Sanjay Shah, but before that, just a minute. We are all in solidarity with the doctors, junior doctors of the Bengal Car Hospital. And with a little heavy heart today, but we will start with the session. Over to Dr. Sanjay Shah.
Yes, good evening, everyone. This time, as Dr. Om Lakhani is talking for the fourth time this time, and I know everyone is knowing him. He is consultant endocrinologist attached with ZS Hospital. He has a very bright career, and not only doctor, he is a man of technology too. So today we are again listening him for a new topic. This time the topic is pituitary gland, and it will be for the primary care physician. So with this introduction, now I invite Dr. Om Lakhani to have his talk.
Thank you, sir. Thank you for the kind introduction. And let me share my slides. Okay, is my screen visible?
Yes, sir, but it's not full screen.
Okay. I guess it's still not full screen now.
No, it is not, sir.
Okay. Okay, I hope it's visible, ma'am. So I think we can.
Yeah, it is visible though. Yes.
Yeah, it's visible, no? Okay.
Yeah.
Fine, fair enough. Okay, so I think we'll have to work with that because I'm sharing it from my iPad so that I can draw on it. Okay.
I can get it.
Workup setup. Okay. Once again, good evening, everyone, and thank you all for joining for this session today. And today is something very interesting. We are going to discuss yet another organ which is often a mystery in primary care, and we're going to discuss about pituitary disorders, and we're going to go through both the physiology and the pathophysiology and the clinical aspects of pituitary disorders. We're going to discuss a lot of these hormones, and we'll also tell you some practical points that you need to understand while dealing with pituitary disorder. So when we talk about pituitary, you have the hypothalamo-pituitary complex, which includes three organs. You have the hypothalamus, you have the anterior pituitary, and the posterior pituitary, right? So these are the three parts which compose what is known as a hypothalamo-pituitary complex. Now, there are few things which are considered golden rules of endocrinology, especially with related to pituitary endocrinology, right? So these are rules which, if you understand these rules, you will understand endocrinology to a lot of extent. The first rule is remember the feedback. Okay, so remember, we all understand this concept that as we saw in thyroid, there is something called a feedback loop. Okay, so you have the TRH, which stimulates the TSH, which stimulates the free T3 and free T4 production, right? And this free T3, free T4, it kind of goes and gives a negative feedback on these cycles, right? So this is the same rule which applies for almost all pituitary hormones, that there is a negative feedback loop, and this negative feedback loop goes back and causes a suppression. So this is one rule which we also have to understand. Second very important rule is again related to the first rule, that is, if a hormone is high, we should try to suppress it. If the hormone is low, we should try to stimulate it, right? It's very important that when we, it's very important that we understand that while measuring pituitary hormones, it's not just important to measure the point value of the hormone, but we need to consider either suppressing or stimulating it to get the correct response. For example, if you are suspecting that the ACTH is high, right? So ACTH high produces more of cortisol, which produces a syndrome called Cushing syndrome. Okay, so if you are suspecting Cushing syndrome, what you should try and do is you should try and suppress the ACTH. Okay, so you do overnight dexamethasone suppression test. If you are suspecting something else, that is, if you have like we discussed last time, we discussed about adrenal insufficiency. So if there is deficiency of ACTH, which produces less cortisol, then you have adrenal insufficiency. In that case, you should try to stimulate the cortisol, and this we do by ACTH stimulation test. So we understood this point that whenever the hormone is deficient, you should try and stimulate it. When the hormone is high, or you're suspecting that the hormone is high, you should try and suppress it, right? So that's a very important fundamental rule. And then remember, all the lab values are relative. Okay, this is something which is very important again in endocrinology. A lot of primary care physicians make a mistake at this point of time, right? Lab values are relative to the clinical state, right? So I think we discussed this a little bit last time. Now, if a patient has, if a patient is in ICU, right? If a patient is in ICU and the patient's cortisol value is 15, right? Would you consider this to be high, low? It is considered in an ICU, it is considered to be low, right? Whereas if the same value is there in a patient who is in a normal physiological state, this is considered to be normal. Okay, so you have to see that what is the level of the hormone with regards to the physiological status, right? So this is very important, and this is something which you need to understand. And very importantly, pulse is life, right? So we need to understand that the hormones of pituitary are pulsatile, right? So they're pulsatile in nature. So, this is how a growth hormone is typically released, right? So it is often pulsatile, for example, right? So sometimes, we make a mistake of measuring growth hormone, right? So if the growth hormone is measured at this point of time, the value will be a little bit higher side. If it's measured here, it will be lower, right? So that's why we have to understand that hormones are often pulsatile. And hence, you have to understand that you have to consider that this pulsatility is also an important factor that should be taken into account. Okay, so these are some golden rules of pituitary physiology. And now looking forward at the hormones of the pituitary gland. So you have the anterior pituitary hormones and the posterior pituitary hormones. So the anterior pituitary gland releases these hormones. You have growth hormone, you have thyroid stimulating hormone, TSH, LH, FSH, prolactin, and ACTH. So there are 6 hormones produced by the anterior pituitary. And then you have 2 hormones which are produced by posterior pituitary, which is vasopressin, ADH, and oxytocin. Okay, so if you see the picture here, right, you can see the various hormones which are released by the pituitary gland, right? So you have the ACTH, TSH, LH, FSH, prolactin, and growth hormone, right? And then you can see the downstream effect of these hormones. We'll discuss this in a few minutes. right? So these are all anterior pituitary hormones. And then this is the posterior pituitary, which releases ADH, vasopressin, and oxytocin. Okay, so these are the hormones released by the posterior pituitary. Okay, so now let's start with each of these hormones, and we'll discuss a little bit about clinical aspects of these hormones in detail. So let's start with the prolactin first. Okay, so the prolactin, very interestingly, unlike the other hormones of the body, right? So if you see other pituitary hormones, they are generally stimulated by the hypothalamus. Remember this concept that the pituitary hormone, the hypothalamus, generally stimulates pituitary hormone. For example, classical example I'll give you is CRH, right? So CRH stimulates ACTH, right? But very interestingly, prolactin, it is opposite. Okay, in prolactin, hypothalamus actually, it's under constant inhibitory control. So it is under inhibition. So hypothalamus actually, if you talk about prolactin, right, you have via dopamine, there is inhibition of prolactin. So it is under inhibitory control, right? Unlike the other hormones, which are generally under stimulatory control from hypothalamus, prolactin is under inhibitory control. So if, for example, the connection between hypothalamus and pituitary gland is cut off, in that situation, what happens is all the other hormones are reduced, but prolactin is increased. This is exactly opposite to the other hormones, right? So the other hormones, because if the connection between, if the signal between hypothalamus and pituitary is cut off, then the other hormones are reduced, but prolactin is increased, right? So this is exactly opposite to other hormones, right? So it is under inhibitory control via dopamine receptor, right? So that's something very important that we need to understand. And another hormone, very interestingly, TRH, which is also a thyroid related hormone. So TRH actually stimulates two hormones. It stimulates TSH as well as prolactin. Right? This is again something very interesting, which a lot of people are not aware, that the thyroid hormone, the thyroid receptor, the thyroid stimulating hormone is, the TRH hormone, the thyrotropin releasing hormone, stimulates both TSH as well as prolactin, right? So that's something again which is very important to understand. Okay, so this is another important thing. Also remember that prolactin is an acute phase reactant. That means any patient who is in a stressful situation, the prolactin value will be high. And finally, prolactin is released in a pulsatile manner. So that's something which is again very important to understand. Now, what are the physiological roles of prolactin? What does prolactin do? So prolactin basically, it's involved in inhibition of sexual activity and reproductive function. Remember, prolactin is the main hormone for lactation. Okay, so generally when a female is lactating, you want an ovulation, right? So what high prolactin does is it inhibits the sexual activity and it induces lactation. That's the main role of prolactin. That's why prolactin mainly has role in women and has very little role in men. Okay, so that's something which is important function that you need to understand. Now, normally, any value more than 20 in both men and women is considered to be on the higher side. So 20 microgram per liter or nanogram per ml, right? So another unit is nanogram per ml, but any value which is more than 100. So this is very important that if you have a prolactin value more than 100, that is when you should definitely consider looking for an MRI, because the patient could have a prolactin secreting tumor. Okay, so that's a very important message you have to understand as far as prolactin is concerned. Now I'll give you some other practical tips about prolactin. Now, sometimes what happens is that you're suspecting that the prolactin is high. Now, if you're doing, let's say you do a prolactin in a female patient, in a pregnant patient, right? Or if you do a prolactin value in a lactating mother, the prolactin value is likely to be high. Same thing also happens in patients who are having hypothyroidism, right? Patient having primary severe hypothyroidism. Sometimes the prolactin values are very high, right? And because of this, right, sometimes there could be pituitary hyperplasia, right? So in this case, for example, you can see the pituitary gland is enlarged, but it is hyperplasia and not adenoma. There is no tumor, right? So it's a hyperplasia of the pituitary gland. So this differentiation is very important to understand. And the difference is basically when you see a pituitary hyperplasia, there is a tabletop sign, right? So it's like a mountain top, right? So when you have the pituitary gland like the mountain top, that is basically the pituitary hyperplasia and not a adenoma. Now, another very important, this fact I already told you, that hypothyroidism itself increases prolactin. So sometimes we get a lot of referral of patients who are already hypothyroid and the prolactin is also done, which is high. What again, a lot of doctors need to understand is that hypothyroidism and prolactin, this is the relation. So when you have a primary hypothyroidism, right? So when you have the primary hypothyroidism, that situation, what happens is that the negative feedback on the TRH and TSH is reduced. Because that negative feedback is lost, that means what happens is there is more TRH being released, and hence TRH, remember, stimulates both the prolactin as well as TSH. So in primary hypothyroidism, you can expect that the prolactin will be high, right? So that's why it's generally not a good idea to measure the prolactin in a patient with uncontrolled or untreated hypothyroidism, right? You should first treat the hypothyroidism and then measure the prolactin. So that's a very important message that you need to understand. So when not to measure prolactin, this is something important. Like a lot of times we see patients, prolactin test is done, and then you have difficulty in interpreting this report. So there are two situations where you should not measure prolactin. You should not measure prolactin when the patient is in a physiological stress. For example, patient is having fever, patient is having some other infection. In that cases, you should not measure prolactin. And secondly, when the patient is in pregnancy or lactation, naturally the prolactin values will be high. So in this situation also, you should consider not measuring the prolactin. These are the situations where you avoid measuring the prolactin, right? Another very common mistake which a lot of gynecologists have seen make, you do a pool sample. Pool sample means every 10-15 minutes you take a sample of prolactin. This is a lot of labs do this, but it is not required. Recent studies have shown that pool sample is generally not required. Okay, so keep this in mind, that pool test is not required. So you can do a direct test. Directly you can measure the prolactin without doing a pool sample, but the prolactin value has to be measured in the morning fasting. Okay, so this is something which is very important. So these are some important tips about prolactin. Now let's discuss another hormone, which is very important hormone, which is growth hormone. Okay, so what is the physiology of growth hormone? So once again, remember the control comes from hypothalamus. So hypothalamus releases growth hormone, releasing hormone. But very interestingly, in this case, hypothalamus has both. So we saw with prolactin that hypothalamus inhibits the prolactin, whereas in growth hormone, hypothalamus both stimulates as well as inhibits the growth hormone, right? So through hypothalamus, there is growth hormone releasing hormone, GHRH, which stimulates the growth hormone. And you have the somatostatin, which inhibits the growth hormone, right? So you have both these hormones which are released by the hypothalamus. So there is a physiological state, right? Now, pituitary releases the growth hormone. And this growth hormone basically goes to liver. And in the liver, it produces a hormone called IGF-1, right? So most of the function which is done by growth hormone is done via IGF-1. Okay, so the hormone which you should ideally measure, right, is not growth hormone. The hormone you should measure is IGF-1, right? Now, this is something which, I'll come to this point. Remember, growth hormone is in a pulsatile state, right? It is released in a pulsatile manner. The peak occurs at night time, which correlates with the sleep onset. And remember, growth hormone is also present in adults also. So a lot of people think that only growth hormone is present in children. That is not true. Growth hormone is present in adults as well, right? And the release of growth hormone is in a pulsatile manner, right? So the pulsatile manner is very important. Now, this is something very, 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 very important, right? So again, a lot of pediatricians also make the same mistake. You should not directly measure growth hormone. There is no point of measuring growth hormone directly. Why? Because growth hormone is pulsatile. So if you measure the growth hormone, sometimes you might measure at the peak and sometimes you might measure at the trough. So you will get erroneous values. That's why it's not important. You should not measure growth hormone directly, right? There is no point of direct measurement of growth hormone. This is, sometimes you refer to see that any person, any doctor is well versed with endocrinology or not. We see that, we do this little thing, right? If a doctor orders for a growth hormone directly, that means that the doctor is not well versed with the concepts of endocrinology, right? It's a very important thing to understand, that do not directly measure growth hormone. It has no value, right? Except in certain cases of acromegaly where there is growth hormone excess and you have done pituitary surgery. In that case, measuring growth hormone is important, but it is more important to measure the IGF-1, the test you have to do. If you're suspecting either growth hormone deficiency or excess, the test you should consider doing is IGF-1. This is the test you should do because it is a longer half-life, it is more stable, right? So IGF-1 is so if you're suspecting that a child is short or child is tall, then the test you have to do is IGF-1 and not growth hormone, right? So if you're suspecting that the child, a lot of the time you have children who are short, right? And one of the very important causes of short children is growth hormone deficiency. So whenever you're suspecting a growth hormone deficiency, you should consider stimulating. I already remember this fact I told you, that when the hormone is excess, try to suppress it, and the hormone is deficient, try to stimulate it, right? So when you're suspecting the growth hormone is deficient, you should try and stimulate the growth hormone. And stimulation of growth hormone in India, we do two tests which are done commonly. One is clonidine stimulation test and other is glucagon stimulation test. If you are suspecting that the child has having growth hormone deficiency, the first test you do is IGF-1, right? And if IGF-1 is low, then you should send the patient to an endocrinologist for further treatment and management. And generally in our practice, we do a chloride stimulation or a glucagon stimulation test to look for growth hormone deficiency. However, if the growth hormone is in excess, like you are suspecting acromegaly, in that case, you should do oral glucose growth hormone suppression test. So glucose actually suppresses growth hormone. So that's something, again, you have to understand. So if you have a patient with acromegaly, we do a oral glucose growth hormone suppression test to diagnose acromegaly. Another very important thing you have to remember that a lot of children are given steroids for some other reason. For example, we discussed this last time a little bit with drug-induced Cushing syndrome or steroid-induced Cushing's or exogenous Cushing syndrome. You have to remember that steroids, right, glucocorticoids inhibit growth hormones. That's why a lot of children who are on steroids for some reason, for example, nephrotic syndrome or any other condition, these children are likely to be short because the steroids inhibit growth hormone release, right? So that's an important message you have to understand. And IGF-1, like I told you, is the hormone you should measure rather than the growth hormone, because IGF-1 is more stable. It is a longer half-life, and it's very easy to measure. So this is the test you should consider doing when you're suspecting growth hormone deficiency. Okay, so these are some very important aspects about growth hormone. Then let's look at ACTH. Now, we already discussed a lot about ACTH in the last discussion we had about adrenal insufficiency. So I'm not going to go into too much detail. We already discussed the HPA axis. That is, I told you that CRH increases ACTH, right? So I told you this. So you have CRH, corticotropin release of hormone, which releases ACTH, which releases cortisol, right? And then you have this negative feedback where the cortisol inhibits the CRH and ACTH. Okay, so this is the entire cycle that you understand. So very important to understand that again, ACTH, this is known as the hypothalamo-pituitary adrenal axis, right? So we already discussed it in detail last time. Again, something about ACTH you should understand that it's very important that it has a circadian rhythm, right? And the ACTH values peak early in the morning and levels are very low at midnight. Okay. So again, when you're measuring cortisol or measuring ACTH, you have to understand that you have to measure it in the morning time, right? If you measure it late in the evening or rest of the daytime, then you are likely to get a erroneous result, right? So that's something which you have to understand. Some other practical tips you already discussed about adrenal insufficiency last time, so I'm not going to detail. You have primary, secondary, tertiary adrenal insufficiency. You can go back and see the earlier video on this topic. And already discussed about exogenous Cushing. So if the patient is on steroid from outside, then the patient is likely to have HP axis suppression and have adrenal Cushing syndrome. Okay. Remember, ACTH is a stress hormone. So whenever the physiological stress is activated, you have the ACTH which is released in excess. And again, if the patient is having adrenal insufficiency and this stress, hormone is not produced enough, then the patient can develop serious consequences of adrenergic crisis. Now, another very important thing I told you last time, don't forget this, right? This is something which is very important, hyponatremia. Okay, I already told you there are two very important causes of hyponatremia or low sodium that you cannot miss. One is adrenal insufficiency. Other is hypothyroidism. Okay, so always remember this, right? Whenever you have hyponatremia, rule out adrenal insufficiency and hypothyroidism. These are two conditions, right? And remember, this is something very, very important. So we already discussed this last time. I'll again not go into too much detail of the physiology why it happens, but this is something you need to understand in primary care, that whenever you have a patient with low sodium, right? If the patient has low sodium, okay, so you have low sodium, then two tests you should always do. One is serum cortisol, right? Another is thyroid function test, 3T3, entire thyroid function, 3T3, 3T4, TSH, right? These two tests you should always do whenever your patient has a low serum sodium, right? So this is, again, this has to be done in fasting. So always remember this very important practical tip, right? That whenever you have a patient with low sodium, these are the two tests you should consider doing. Okay, now, again, we discussed this, right? So what happens, so if you are thinking that the ACTH is excess, what will you try to do? ACTH excess is known as Cushing syndrome. So we have excess of ACTH, you try to suppress it. So we do a dexamethasone suppression test. And when you're suspecting adrenal insufficiency, we do a ACTH stimulation test, right? So again, if the hormone is in excess, try to suppress it. If the hormone is deficient, try to stimulate it, right? So that's a very important message you should consider doing. Now, what about directly measuring ACTH? Now, ACTH measurement, you have to remember this physiological aspect. It's very important to understand that whenever you're measuring ACTH, the few rules have to be remembered. One, it has to be done always morning, right? Remember, I told you it's in a circadian rhythm. So ACTH values will be very different in the morning compared to evening or afternoon or night time, right? So that's something which is all of us have to remember. Secondly, you have to remember that whenever you are measuring the ACTH, that the ACTH value often declines very rapidly. So you should ideally consider collecting the sample in a pre-chilled EDTA tube, right? So when you have EDTA tube, it should be chilled before, right? And it should always be transported to the laboratory in ice. So if the test is not done in the same laboratory, it has to be sent outside. It has to be sent in an ice pack, right? Otherwise, the chances are that the value will be falsely low, right? Or else what you can do is, if you have again some local lab available in your hospital or in your clinic, then you can centrifuge the sample and separate it, right? And then you can freeze the plasma and send it for sampling. So you can keep that. That is another way of doing the ACTH assay. So these are all things you should remember when you are doing the ACTH assay. Let's then move to the next group of hormones for pituitary, that is FSH and LH. Okay, so here you have the hypothalamo-pituitary testosterone or hypothalamo-pituitary gonadal axis, right? Now, hypothalamus releases a hormone called GnRH, right? And GnRH acts on the anterior pituitary to produce two hormones, LH and FSH. This LH and FSH work on both male and female hormones to produce the sex hormones. So in males, it produces testosterone, in female, it produces estrogen and progesterone. Okay, so this is the role of FSH and LH. Right, now let's see the physiology in men. Okay, so in men, what happens? Okay, you have to remember that you have the GnRH, which acts on pituitary to produce LH and FSH. Right, now what these two hormones, both of them in men, have different roles. So LH, what it does is it produces testosterone. Right, the role of LH is to produce testosterone, whereas FSH produces sperms. Right, so both these hormones have different roles in men, right? So LH is mainly involved in production of testosterone and FSH is involved in sperm. Right, now let's say, for example, some patient has again pituitary deficiency or surgery, right? Then what will happen is both the LH and FSH will be reduced. So the testosterone will also be reduced and the sperm production will also be reduced, right? So this is an important rule that you have to understand. You can see here this chart here. Okay, now, so some practical tips, right? Another important thing about GnRH is that it is pulsatile. Okay, so GnRH, if it is pulsatile, then it increases the FSH-LH. But if you give a constant GnRH, it suppresses the FSH-LH. Okay, this is very interesting. Why this is interesting? Because there is an agent called leuprolide. You would have heard about this being used in cancer. Okay, so leuprolide is an agent which is used in various types of cancer. So in men, it is used in prostate cancer. Right? In females, it is used in various forms of cancer. For example, in case of endometrial or ovarian cancer. Right? So what it does is leuprolide is basically synthetic GnRH. Right? It's a GnRH agonist. Okay, so it's a GnRH agonist. So you will say कि अरे GnRH दे रहे हैं तो ideally hormone बढ़ना चाहिए, लेकिन hormone कम हो रहा है. ऐसा क्यों हो रहा है? Because when GnRH is given constant, right? When you give constant GnRH, right? Constant GnRH basically suppresses LH and FSH, right? Whereas when GnRH is given in a pulsatile manner, it stimulates FSH. Right? So this is a very interesting physiology that you need to understand, right? So that's why I told you pulse is life, right? So pulsatile hormone, when it is released, it is important. Whereas if it is released, steadily, right, it can lead to these issues, right? So that's something which is important, right? So these are some important aspects. So whenever you have a patient with hypogonadism, now one more important aspect I'll just add here, right? Prolactin. Okay, we already discussed this hormone. So prolactin, it suppresses FSH. It's very interesting. Okay, so prolactin basically is also a hormone which is produced by pituitary gland. But when prolactin is in excess, it suppresses the LH and FSH. Okay, so again, a lot of the patients, when you are suspecting hypogonadism, right? So in men, what will be the signs of hypogonadism? So the shaving frequency will reduce, there'll be erectile dysfunction and so on. So whenever suspecting hypogonadism, you will do these tests: LH, FSH, prolactin and testosterone. What will happen in women, right? So in women, when you have excess of prolactin, they will again have amenorrhea. Again, FSH and LH will be suppressed, so they will develop absent periods or amenorrhea. Right. So these are the important things you have to understand while dealing with various hormones of the pituitary gland. Right. Okay. So these are some important things. Now let us look at the TSH hormone. Right. So remember, TSH is, a lot of people forget. TSH thyroid. No, TSH is not thyroid hormone. TSH is a pituitary hormone. Right. TSH is a hormone which is produced by pituitary. So this is the axis. We already saw this picture earlier. So hypothalamus produces TRH. TRH both acts on prolactin as well as TSH, and this TSH acts on the thyroid gland to produce T3 and T4, and this T3 and T4 suppress the anterior pituitary and the hypothalamus. Okay. Now some practical tips about about thyroid function, and this is something I'll discuss a case here, right? So a 50-year-old lady comes with history of weight loss, dullness, tiredness, loss of appetite. Now when you do the TSH, right, the TSH is low, right? TSH is 0.1. Right. So what is the diagnosis? Is it hyperthyroidism? Is it hypothyroidism? Or would you say it needs further evaluation? Now, ideally, in this cases, you require further evaluation, right? So we also ordered free T3 and free T4. Now, in this case, what happened was, right, the free T3 was also low, free T4 was also low, and TSH was also low. Okay. So is this hyperthyroidism, hypothyroidism? This is basically central hypothyroidism. I think we discussed this a little bit when we discuss about thyroid, right, and other things, right? So this is a very important message you have to understand. I think we discussed with this thyroid. I think we discussed this in some other lecture as well. So something very important to understand, that all TSH low, whenever TSH is low, it does not mean that patient has hyper. Sometimes the patient could have exactly the opposite. Patient could have hypothyroidism also. Okay. So this is very important. So always do a complete thyroid function, T3, T4, and TSH. And if the TSH is low along with the T3 and T4 also low, then it is central hypothyroidism and not hyperthyroidism. Okay, so this is a very important message here to understand. So in this case, patient basically had a central hypothyroidism, and in this case, we found that the woman had a Sheehan syndrome. Right? Sheehan syndrome is a condition that happens after delivery. Right. So after delivery, what happens? Some women, because if they have postpartum hemorrhage, enough blood does not go to the pituitary gland, and if enough blood does not go to the pituitary gland, sometimes they can develop adrenal insufficiency, and other hormones are also deficient. So whenever you have this type of patient where you have the central hypothyroidism, remember, always check the other axis also. It's very important that you also check the other axis apart from the thyroid. And then always remember, a lot of the times the thyroid hormone loss is not seen first, it is always sometimes seen last. So patient will often have adrenal involvement also. So they'll have, central adrenal insufficiency also and hypothyroidism. And this we discussed last time as well. Whenever you have both adrenal and thyroid deficiency, you should always treat the adrenal deficiency first before treating the thyroid deficiency. So that's something which is very important. Okay. So these are some important things we have to understand as far as the thyroid is concerned. Right. Now, so this was all about anterior pituitary. Now let's look at the posterior pituitary. Right. The posterior pituitary produces a very, very important hormone, that is vasopressin, that is antidiuretic hormone. Now, what is important to understand, that this posterior pituitary itself does not produce any hormone. It is basically this vasopressin or antidiuretic hormone is actually produced by hypothalamus, but it is released by posterior pituitary. Right? So it comes through posterior pituitary and then it is released to the circulation. So vasopressin or antidiuretic hormone has two very important roles. First is, it acts on the kidney, as the name suggests, it is antidiuretic hormone. So it produces free water reabsorption, right? Free water. So it basically reabsorbs water without absorbing sodium. This is very interesting because all the other hormones, right? For example, the aldosterone and the other hormones of the body, all the other hormones of the body, they, reabsorb fluid along with sodium. But vasopressin is one hormone which just reabsorbs the fluid without reabsorbing sodium. Okay. So understand this point, right? So you have two hormones which reabsorb sodium. Sorry, reabsorb fluid. Aldosterone and ADH, antidiuretic hormone. So aldosterone from kidney, it reabsorbs water plus sodium. Whereas ADH basically reabsorbs water minus sodium. Okay. So this is important. So whenever you have ADH, what happens if ADH is excess? More amount of water is being reabsorbed, but sodium is not reabsorbed. And in this case, you have dilutional hyponatremia. Right? So which condition produces ADH excess? This is known as SIADH, serum of inappropriate ADH secretion, SIADH, right? You all heard of this condition. So SIADH is a condition where you have excess of ADH, and because you have excess of ADH, right, the water fluid is reabsorbed, but sodium is not reabsorbed, and hence you have hyponatremia. Okay, so this is very, 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 very important. Okay, so today we learned 3 very important endocrine causes of hyponatremia. In fact, 90% of hyponatremia are because of one of these 3 causes. Either you have SIADH, or you have adrenal insufficiency, or you have hypothyroidism. These are 3 conditions, right? 90% of cases of hyponatremia are because of one of these 3 conditions. Okay, 10% are because of other causes, right? But these are very, very important. So whenever you have hyponatremia, always refer the patient to endocrinologist, not to other specialists. This is a common mistake a lot of people make, right? Because 90% of the causes of adrenal insufficiency or of hyponatremia are endocrine causes. First, you have to rule out endocrine causes, and then you consider other causes, right? So that's something which is important message you have to all understand. Okay. The second role of vasopressin is that it produces vasoconstriction, right? And it increases the blood pressure. So these are the function of vasopressin. You would have heard vasopressin being used for CPR or for, in place of adrenaline, you can sometimes use vasopressin. So that's basically because it increases the blood pressure, right? So that is one other role of vasopressin. Okay, so again, some practical tips. So I already told you, excess of ADH is known as SIADH, which produces hyponatremia. Right. Now, what happens when you have ADH deficiency? Deficiency of ADH is a condition known as diabetes insipidus. Right. So what happens in diabetes insipidus? Polyuria. Right. This is the other form of diabetes which a lot of people don't know about. So whenever you have, this is produces extreme amount of urine. So patient often passes 6 to 8 liters of urine in a day. Right. This is because of deficiency of ADH, which is known as diabetes insipidus. Okay. So diabetes insipidus, often the sodium will be high or normal, right? But in diabetes insipidus, you can never have hyponatremia, right? So that's something which is important to understand, right? So this is the ADH related pathophysiology, right? So I already told you sodium and ADH. Remember this point, diabetes insipidus patients almost never have hyponatremia. So if you have hyponatremia and the urine output is high, it is almost never likely to be diabetes insipidus. Also remember, polyuria with normal or high sodium, it is suggestive of diabetes insipidus. Whereas polyuria with hyponatremia, it is unlikely to be diabetes insipidus. So it's an important rule of thumb you have to remember. Okay, now one interesting thing you have to remember, I already told you this. So again, very important, central adrenal insufficiency and ADH, how is this connected, right? So this is a very interesting aspect of physiology, which a lot of people don't understand. Now we already discussed that ACTH produces cortisol. And ACTH is under the control of CRH. So CRH stimulates ACTH. But a lot of people don't understand that ADH also stimulates ACTH. Okay. So CRH stimulates ACTH and ADH stimulates ACTH. And cortisol has negative feedback on both. And that is the reason why you have deficiency of cortisol increasing. Deficiency of cortisol, removing this negative feedback, so ADH increases, and that's why you have hyponatremia. Right? So that's why adrenal insufficiency, both central and peripheral and primary, both are associated with adrenal with hyponatremia. So this is again and again I'm repeating. So I think if one take-home message today, hyponatremia should be referred to endocrinologist because majority of the causes of low sodium are endocrine causes. Oxytocin is the final hormone. Oxytocin is basically considered the love hormone. Okay, it is the love hormone. Right now, oxytocin is basically involved in release of the milk, right, during nursing period, but it is also helps in the contraction of uterus during labor. So this is the function in during delivery and in postpartum. right? But what is the role in general? Well, we don't know much about oxytocin, but it is thought that oxytocin is, like I said, the love hormone. So that is the hormone that, with which you develop an attachment to your family members, to your children, both men and women, or to your spouse, or to somebody you love, right? So oxytocin is the hormone with which you develop the attachment to another human being, and that is the role of oxytocin. So there's not much known about oxytocin in endocrinology, even though it has been around. And it's one of very frequently used hormone, especially during labor. But we don't understand much about oxytocin per se, and there's still a lot of research going on as far as oxytocin is concerned. So with this, I'll end, right? But I'll give you some take-home messages for today, right? So first tip, always remember the feedback. Remember that there is a feedback loop, right? So always remember this point that you have the the TRH which stimulates TSH, which stimulates the thyroid hormone, and then there's a negative feedback, right? Same with all the other hormones, right? Except for prolactin. Remember, prolactin is under inhibitory control. Second very important tip, right? If a hormone is high, try to suppress it. If the hormone is low, try to stimulate it, right? That's the general rule, right? So for example, you are suspecting Cushing syndrome, you do a dexamethasone suppression test, and you're suspecting a deficiency of cortisol, then you do a ACTH stimulation. And third important thing, remember lab values are always relative. So for example, a low value in a young prepubertal male, I sometimes get referred 7-year-old children with low testosterone. Now, 7 साल के बच्चे का तो testosterone low ही होगा, right? So always remember the lab values are always relative to the clinical and physiological state of a patient, and don't whenever you interpret this report, right? Always try and understand that the report has to be interpreted in the context of it, right? Pulse is life. Remember, growth hormone is a pulsatile hormone, so sometimes never do that. Never measure growth hormone in isolation, right? If you're suspecting growth hormone deficiency or excess, measure IGF-1 and not growth hormone, right? So that's another important rule you should all remember. Okay, so this is all for today. If you have a relevant patient for online consultation, this is the QR code you can follow. And we do a lot of endocrinology thing also. So again, if you're interested in anybody of, I'll be sharing the links to Dr. Pragnesh as well. So anybody interested in we are having a talk tomorrow on how to use artificial intelligence for making presentations. So if you're interested in this talk, it will be at about 8:30 p.m. tomorrow. So if you're interested in this, you can follow me on Twitter. I'll post the links there, or you can get in touch with Dr. Pragnesh for more information. Right? So connect with me on LinkedIn. I'm available on LinkedIn, and thank you for a patient listening.
Thank you very much, Dr. Om. As usual, it was a very enlightening talk. And as of now, I do not see any questions on the YouTube. Dr. Sanjay, if you have anything.
Yeah, actually, I was also absent in initial 15-20 minutes because of my OPD timing. But whatever I listened him in last 20-25 minutes, the talk was very excellent. Talk on pituitary hormone, I think it is just like 1 + 1 = 2, but you must know what is 1 and what is 1 again. So then and then you can understand each and everything. So we in family practice actually see very less number of patients of pituitary hormones related disease. But as you said last time, last thing, that hyponatremia, which we quite often see in old aged patients. So it's a cup of your tea, endocrinologist cup of tea. And what we understand that it's a nephrologist cup of tea. So that is today I understand. And there are lots of things in endocrinology, and there are most of the causes of hyponatremia are related to adrenal and these pituitary hormones.
So before we close,
and again, I think another common thing that we see in primary care practice, if you're seeing children as well, you might see a lot of short children with short stature, right? So that is one of the very important, so whenever you're suspecting, I think again, another tip I'll say to all the primary care physicians, if you have a child with short stature, do an IGF-1, right? IGF-1 is a very important and simple to do test. Most labs do an IGF-1. So if you're suspecting a child is having short stature, don't do growth hormone, do IGF-1. And then, if the IGF-1 is low, that child should be then referred to endocrinologist for further evaluation. So that's another place where you often see in primary care practice, very important use for pituitary hormone. And finally, I'll give one more place where, we often require pituitary hormone. Like I said, if you have a young woman or if you have a woman with amenorrhea, right, with, the periods are infrequent or the women has not had periods for a long time, a very important test we could do for such women are prolactin, right? So again, prolactin is a very useful test in such situations. So I think these are 3 or 4 places where, pituitary, we come across pituitary diseases quite day in, day out. So I think these are the places where you should consider testing and then sending it to appropriate endocrinologist.
One question for you, Dr. Om Lakhani. I know a patient who's got a neuroendocrine
Yes.
and she's treated with somatostatin. It is not very progressive, not very aggressive. So every month somatostatin. So what is the logic or how does it work?
Yeah. So somatostatin, basically neuroendocrine tumors have somatostatin receptors, right? So, so when you give somatostatin, actually blocks the receptors and prevents the growth of neuroendocrine tumors, right? So especially neuroendocrine tumors. So it's a very commonly used treatment now. So if you have a neuroendocrine tumor which is picked up on a DOTA scan, you have this DOTA PET scan and all that. Yeah. So that, DOTA PET scan itself is a marker for somatostatin receptor. So if you have, a tumor positive on DOTA PET scan, that means that the tumor will respond to somatostatin. In such cases, we give somatostatin every month, which prevents the growth of the tumor. So it inhibits the growth. It's like a anti-cancer treatment, but a hormonal form of anti-cancer treatment. So it prevents the growth of the tumor. So that's what it is used for. So whenever you have a neuroendocrine tumor with DOTA positive, that cases we generally give them somatostatin every month. So we generally give a 20 or 30 milligram monthly intramuscular injection. So that prevents the growth of the tumor and keeps it under control.
And in such cases, how frequently should a DOTA scan be done?
Well, DOTA scan, it depends on case to case basis. So generally, most cases, we generally do it annually. So once a year, we just see for progression of disease. If the disease is more aggressive, we can consider more frequent evaluation also. And again, if the it's a hormone producing tumor, for example, insulinoma or other things, then you have to probably consider other form of treatment also. There is something called PRRT, which is also given, right? So those cases. So basically, but as a rule, generally, annually we do for lower grade tumors, we can do an annual DOTA scan to monitor such patients.
So if it is not very aggressive or not very thick, PRRT may not be required.
PRRT is only mainly required for more aggressive tumors which are not responding to somatostatin.
Thank you. Maybe it was a little out of the topic, but
no, ma'am, it was perfect. So yeah, I mean, neuroendocrine tumors itself is a
vast subject.
Vast subject. Very interestingly, neuroendocrine tumors is something which a lot of doctors don't know about. It falls right in the crack of a lot of specialties. Oncologists know a little bit about it, endocrinologists know a little bit about it, neurologists know a little bit about it. So it's something which falls, right in middle. So it's a very interesting area, right? And it's an emerging area, and these are very treatable forms of tumors, right? So again, something so there is in fact a neuroendocrine society also, neuroendocrine tumor society in India and abroad. There's European neuroendocrine tumor society also. So it's a very interesting and emerging area of science. And a lot of other cancers also, like breast cancer and ovarian cancer, also may have neuroendocrine manifestations also. So that's also something which is important.
Very interestingly, I've had 2 neuroendocrine tumor patients within a span of 3 months. One was an insulinoma, which was removed. So it was operated surgically. Even on the chat, even now, I don't see any questions, but there are compliments saying that it was a very informative and very enlightening talk.
This time attendees are less, so there are no questions in YouTube also. But I think so many doctors will listen to you in as a recording program, and they will ask questions as you gave in your address to ask the patient. So other doctors will also listen the recorded program. But I think this talk was really light giving on pituitary hormones, and it will be definitely helpful in our practice. Thank you, sir.
Thank you so much. Thank you.
Thank you,
you,
sir.
Thank
Thank you,
ma'am.
Rahul. And on behalf of FFPI, I thank all the viewers, all those who have joined us. We are there because of you. And please make use of
Yeah.
these sessions. Even if you have missed it, please tell your friends to see the recorded session. These are all recorded and they will be uploaded on the FFPI YouTube channel. Thank you. Thank you,
ma'am.
sir.
Thank you.
Thank you, Rahul. You
Good
can
night.
end the
Thank you.